Lupus nephritis is diagnosed by the clinical scenario: fever, rash, arthalgia, renal involvement, CNS involvement, joint involvement, bone involvement, muscle and different organs. Along with it, the lupus serology, like C3 low, C4 low, and anti-DSDNA positivity, and the screening test is always ANA positivity, which is found in 98% of cases. In renal cases, nephritis is being diagnosed by renal biopsy. There is histologically it has five types. Stage 1, minimal involvement, minimal mesangial reaction. Stage 2, mesangial proliferation. That do have minimal renal presentation. The treatment of those cases depends upon the extrarenal presentation. If they do have little bit of external disease, they should be given prednisolone and hydroxychloroquine, antimalarial drug useful in the lupus flare prevention, lupus disease progression, as well as in the your disease regression. So prednisolone up to 30 milligram in stage 1 and 2. If you need it, give it, and then over 3 to 6 months taper, and if necessary go for maintenance. So stage 3, 4, your at times 5, they are proliferative lupus. So they need a little bit aggressive immunosuppression with IV methylprednisolone 3 to 6 pulses daily, followed by oral prednisolone 1 milligram per kg per day daily. At 1 month, see the disease activity, whether it has become quiescent or it is active. If it is quiescent, you go on reducing the dose, taper oral prednisolone to 0.2 milligram per kg per month initially until it is 0.5 milligram per kg per month. Then again taper to 0.1 milligram per kg per month until it is 7 to 10 milligram total. When the disease is refractory, no response with all immunosuppressions, hydroxychloroquine, your IV methylprednisolone, your MMF, your combination of three drugs is called multi-targeted or triple therapy. When you do not have any desired response, the best possible drug over here is the IV cyclophosphamide. You can use the equivalent dose of oral cyclophosphamide. No response, again you have combination of three drugs. And then refractory disease, you need to address it with CNM, tacrolimus or cyclosporin. Currently in above 18 years, the FDA approved your voclosporin also. So combine, and again no response, you do the biopsy again, second biopsy over here, and then you go for your newer your other immunomodulating drugs, anti-CD19 group. Belimumab is approved over here, and finally, if no response, you go for the plasmapheresis, and your patient can be sent to the trial medications if there is trial, as it exists in the West. Switch of one group MMF to cyclophosphamide and vice versa is at times useful, and then your good amount of time where your patient has gone into remission. This is the normal scenario but you do have the reverse scenario like CKD progression is possible. In the early stage of CKD 1 to 3, you have your maybe less disease activity or less benefit by immunosuppression, thereby reduce the dose of prednisolone to 5 milligram alternate dose, and then continue with the little amount of MMF and azathioprine, either of the two, and go for follow-up of your disease activity and CKD. In advanced CKD 4 and 5, you do not have any benefit of immunosuppression because this is fibrotic, non-inflammatory tissue, so thereby withdraw the immunosuppression and prepare the patient for the transplant. Patient who has gone to remission, they are likely to flare at any time in their lifetime, lifelong disease. So monitor the disease activity by, as I said earlier, C3CP, your ANA, anti-DSDNA, at times the ENA profile, which includes anti-Smith, anti-Ro, La, J1, Zo, your SCL17 antibody, and finally, if you fail to get the answer, do the renal biopsy. So flare cases again to be dealt with in almost similar fashion with your oral prednisolone, IV prednisolone, and your MMF and and your monoclonal antibodies, as I told earlier. Children has a little bit of worse prognosis because and but the less disease is also because the disease is more aggressive over here, and earlier onset disease is more aggressive. So guarded prognosis, CKD progressions over here is how much? 50%, and 10 to 30% have end stage renal disease, CKD 5, D, and so.